So it's sure that we are in a new era, so many possibilities in a disease that previously was not very well treated. And of course, however, we must admit several things. So considering surgery, nobody likes surgery, but this is the same for the drugs. And not the same, at least in Bulgaria, considering the alcohol, even in the field of the septal ablation. So this is something that we must take into account. So we have several trials, and what I will show in the next minute is one of them. Considering especially into the field of the symptomatic patient with hypertrophic cardiomyopathy, obstructive one, which are candidates for septal reduction therapy. This is quite interesting field, and especially in Valor, we have this direct comparison in a phase 3 study of the medical treatment on the top of the standard medical treatment for the patient with hypertrophic cardiomyopathy. The idea is to compare what will be the results for those quite symptomatic patients. So this is the whole program, of course, which is a long-term, and I will focus your attention on the first phase in which we have a direct comparison of the mavacamten treatment versus placebo for the first 16 weeks of the treatment. And after that, according to the protocol of the study, we have switching of the placebo group, once again to the active treatment. We have also dose titration of the drug that is inside, and final part in which all the patients are treated with the active treatment. So many of these are already published. Once again, I want to show you the result versus placebo, which is the first part of all the picture. Of course, all the patients are candidates for septal reduction therapy, and the idea of this comparison is to see what's happened with the decision to proceed with septal reduction therapy prior to week 16, or what proportion of the patient once again will be eligible for septal reduction therapy after the treatment once again at week 16. We have two composite primary endpoints and several, and this is a list of the secondary endpoint, which is the left ventricular outflow tract gradient, change of NICA classes, functional capacity of the patient according to the Kansas questionnaire, and serial change of biomarkers like natriuretic peptides and cardiac troponin T. So what kind of patients are included? What is obligatory is that those patients are symptomatic and must have been referred in the past 1 year for septal reduction therapy. Apart from this, they must be at least a class 2 with exertional syncope or near syncope, or class 3 and 4 of the symptom therapy. And those are treated patients with mono or combination therapy of beta blocker, calcium channel blocker, or disopyramide. Of course, not the patients who already had septal reduction therapy are excluded, which is the main exclusion criteria. Atrial fibrillation was not exclusion criteria unless it was not anticoagulated, but during the randomization, all the patients with atrial fibrillation are not included into the study. So those are the main characteristics. Several things to mention. You see here the age, which is typical for the diagnostic pathway of the patient with hypertrophic cardiomyopathy. I bring your attention about the functional class of NICA. We see that the majority of the patients, approximately 90%, are highly symptomatic of class 3 of the New York classification. And according to the idea of investigator, they are deemed to septal reduction therapy in the majority of the case of the myectomy and the septal ablation procedure. So the gradient is more than 50%, more than 50. The ejection fraction here you see is approximately 70. And the monotherapy is among half of the patient are with a beta blocker monotherapy. The combination therapy with a combination of a beta blocker, a calcium channel blocker is approximately 35% of the patient. And of course, being symptomatic means also having high level of the biomarkers study. This is the primary endpoint. So you can see that during 16 weeks of treatment in the mavacamten group, so we have a clear reduction of the proportion of the patients who are eligible for septal reduction therapy, which is part of the primary endpoint and which is covered during this relatively few week period. For the secondary endpoint, you can see that we have a clear reduction of the left ventricular outflow tract during the treatment, and also a quite good improvement of the functional class. Please see that the majority of the patients had not only one, but had improvement of more than one functional class during this treatment. Related to the this Kansas questionnaire, you can see that relatively early in the time course, we have a quite significant improvement of the functional class, which is sustainable during this relatively short 16 weeks period of time, together with a quite good reduction of the biomarker like N-terminal proBNP and serum troponin T. Something which is quite important during dose titration, but also for the follow-up of the patient, is the proportion of the reduction of the left ventricular ejection fraction. That you can see that if we have changes, they are relatively few as a percentage, and we don't have a patient with a more severe reduction of the left ventricular ejection fraction less than 30, and quite few patients in which we have a reduction of the ejection fraction less than 50% during the treatment. So the safety is good in reality during this first time period. What we must see, of course, is the change of the ejection fraction and the change of the gradient at rest and during the provocation. So quite good first data that we have in the phase 3 clinical trials about a new player in the field of the medical treatment of hypertrophic cardiomyopathy. And this is, of course, quite challenging new era to find the exact patient in which we may do this, or to find the patient in which the surgical and interventional procedure will be more important to be done. Thank you for your attention.
Тоест излиза, че ако преди казвахме на пациентите по-добре да ти направим алкохолна аблация, защото иначе трябваше да оперират, сега може да им предложим безплатен обяд. Тоест може да им кажем обяд да го плаща касата, но докато пиете тези лекарства, без да има особени странични ефекти, вероятно ще имате много добър ефект и ще може да си живеете живота. Надявам се това да е бъдещето.
Концепцията за ползвателите на безплатният обяд винаги е така интересна. Мисля, че това пак е изключително важно за правилната селекция всъщност и ние да вървим към тези пациенти, при които опциите и възможностите в действителност са тествани. Така че наистина в рамките на кратко, но и вече бяха публикувани данните от по-продължителният период на проучването, мисля, че имаме наистина много добра опция, която да бъде предложена на пациента, да бъде комуникирана с нея, защото като всяко нещо на този свят ще има пациенти и за едното, и за другото. И това ми се струва, че е важно.
Колеги, някакви въпроси? Най-вероятно за в бъдеще ще има мрежа от центрове, които ще могат да предлагат малък камтен. Предполагам, че това тепърва ще бъде уточнено кои и как. Но от сега, тъй като това се очаква да стане в рамките на близките 2-3 месеца, от сега нататък, ако бъдете пациент с симптоматична обструктивна хипертрофична миокардиопатия, може да му кажете окей, струва си да изчакаш малко и с рамките на 2-3 месеца ще имаш опция да опиташ лекарство, което да свърши работа, без да се налага да се рискува нищо с някаква инвазивна процедура. Аз мисля, че това е добрата новина. Добре, благодаря ви, което закрива си подиума.